Good evening to everyone and welcome to today's wonderful evening. Good to see 16 online classmates. Always, any teacher's dream is to have hundreds of students among the audience so that satisfaction to be able to be of some use in your preparation. Being your everyday classmate, benchmate, roommate, tablemate, and preparation mate. Dr. Murali Bharadwaz is available every day evening, 6 p.m. for holding your hand and discussing at least 50-60 questions so that you feel confident, energetic. And please don't forget, we have 427 hours of HD video of 1500 video lectures covering all 19 subjects on the online mbbs.com video library, along with full-scale grant tests, 30 full-scale grant tests, 10,000 PowerPoint slides, and another 10,000 MCQs practiced as quiz tournaments on the Incus app. Everything is being provided as a part of this crash course program. So please don't forget to call our helpline and today only grab your subscription of the crash course. So let's make the great beginning, Doctor. I hope you all have answered these 50 questions. So before we start the session every day, good to see Jagat Acharya, Shailaja, Kavya, Vineet, and many more who are all online. A 15-day-old baby presented to the emergency department with the history of seizures. And the blood tests, they reveal a serum calcium of 5. Good to see Siddhaya and many more who are all online. The serum phosphate is 9. PTH is intact. Generally, hypoparathyroidism is associated with a low PTH if it is a true hypoparathyroidism. But if it is a pseudo hypoparathyroidism, that means it is a receptor level resistance. So that is the reason in those people, PTH is either elevated or normal, but they will have parathyroid deficiency features like hypocalcemia. So whether you take true hypoparathyroidism or the pseudo hypoparathyroidism, in both the scenarios, you have hypocalcemia common denominator. But the difference is, if it is a true hypoparathyroidism, then PTH level is low, whereas pseudo hypoparathyroidism, PTH level is either normal or elevated, is what you need to emphatically remember. So here comes one of the favorite questions of the examiner. How do you differentiate the various parathyroid-related illnesses? Primary hyperparathyroidism, malignancy, sarcoidosis, vitamin D toxicity, they're all the conditions of hypercalcemia. Whereas vitamin D deficiency, renal failure, hypoparathyroidism, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, all of them are hypocalcemic conditions. Low calcium will prevail in all of them. Good to see Jagat Acharya and many more who are all online. So doctor, for some of you who are new to this session, let me tell you once more. Every day evening 6 p.m. to 7:30 p.m. Sometimes if we get delayed, it will be 7 to 8:30 p.m. We will have a chai pe charcha with Dr. Murali Bharadwaz until the NEET PG entrance in March 3rd week. So please mark it in your calendar. Monday ho ya Sunday ho ya Saturday ho, every day evening 6 to 7:30 we have a session together. Before we start the session, we will give you 50 questions as a challenge. Please take the challenge and try to answer. Every question will be rolling on the PowerPoint every 12 seconds. At the end of it, Dr. Murali Bharadwaz will come in and then we will have a discussion. So the whole idea is to inspire you every day with about 50-60 questions of revision so that you can go back to the onlinembbs.com video library and then finish the revision of all 427 hours of HD video, which are already available in the onlinembbs.com video library along with the PowerPoint slides. So, doctor, vitamin D deficiency or renal failure. In renal failure, 1-alpha hydroxylase in the kidney is not available. That's the reason 125 vitamin D cannot form. That's the reason they have hypocalcemia. Similarly, hypoparathyroidism. Normally, parathormone will cause the retention of the calcium into the serum and decrease the calcium into the urine. Normal function of parathormone. Same way, parathormone will make increased phosphate into the urine and decreases the phosphate in serum. So whenever hypoparathyroidism is there, then more calcium is lost into urine. So they develop hypocalcemia. And whenever parathormone is not there, normally parathormone typically lead to phosphaturia. If it is not there, phosphate becomes retained. So that is what you will see. So that is the reason hypoparathyroidism lead to decreased calcium, increased phosphate in the serum and decreased calcium. So normal calcium is 8.5 to 10.5 milligram per deciliter. Normal PTH 29 to 85 picogram per ml and normal phosphate is 2.5 to 4.5. You should not forget. Then what is pseudo-hypoparathyroidism? In this, parathormone is produced normally, but it is unable to act on the receptor. So that is the reason PTH level become increased, whereas all features of the hypoparathyroidism like decreased calcium, increased phosphate will be found. Only difference between hypo and pseudo is PTH is high in pseudo, PTH is low in hypo is what you need to appreciate. But pseudo-hypoparathyroidism people also have certain structural abnormalities. Typically, they will have absent radius and changes in the fingers, etc., etc. So, if everything is normal, calcium is normal, PTH is normal, phosphate is normal, but only those structural features which are seen in pseudo-hypoparathyroidism are seen, then you call it as pseudo-hypoparathyroidism. In this, there is no problem in parathormone, but it has only the structural problems of the pseudo-hypoparathyroidism. इसलिए इसको कहते हैं pseudo-hypoparathyroidism is what you need to remember. So, doctor, many times we discuss this table. This is one of the favorite, definitely sure shot आने वाला question है. So, इसलिए you have to clearly understand, sit with your friend, take a book, take a pen, analyze all these scenarios and understand what happens to calcium, parathormone and phosphate. Barabar? Now, doctor, a child presents with recurrent bouts of severe cough, audible woofing. So what do you want to take? Nasopharyngeal swab if you are suspecting pertussis. A previously healthy 8-year-old boy comes with arthralgia, lymphadenopathy, erythematous rash. He has completed 8 days course of Cefaclor. So that is an important clue. So there is something called serum sickness-like illness, which is typically a type 3 hypersensitivity with immune complex formation. So that is what happens with certain drugs like Cefaclor, sulfamethoxazole, cephalexin, amoxicillin, NSAIDs, diuretics, etc., etc. Whenever you are administering, these are the drugs that can lead to the development of a type 3 reaction, a small vessel vasculitis, and a serum sickness-like illness is what you have to remember. Right-sided isomerism can lead to asplenia. A 5-year-old has come to emergency with burns. पान के साइज छोटे बच्चे में कितना बॉडी सरफेस एरिया होता है? 1% body surface area. So the head of the pediatric child versus that of the adult, you should know the difference. It is 18% pediatrics, whereas it is 9% if it is adult. The front and the back are 18-18 in case of adult. So also in the case of the children. And 9% is the arms, 18% are the legs, 1% are the genitalia. Whereas it is 14% in the case of the legs are 14% in the case of the child. So you should know clearly this rule of 9, which is the favorite question of the examiner. Jaundice in the newborn, one of the most favorite question. अगर आप पूरा pediatrics लिए तो totally there are about 40 topics, doctor. From these 40 topics only 15 to 20 MCQs will come in pediatrics. So there is one list of 957 topics. Please don't forget 957 high yield topics from 1900 from the 19 subjects. If you don't have it, please call our helpline 9000-868-356 to get the 957 high yield topics. In fact, if you go to the online mbbs.com video library, there are 427 hours of HD videos, totally 1500 videos, in which this 957 high yield topics have been completely revised. Okay, so now doctor, physiological jaundice usually peaks after 48 hours. Breast milk jaundice peaks after day 7. It is the unconjugated bilirubin which can cross the blood-brain barrier, leading to the development of the kernicterus, is what you need to remember. अच्छा भैया, breast milk jaundice versus breastfeeding jaundice, इन दोनों breast ही होता है मगर फर्क होता है. Favorite MCQ of examiner. 13% of the breastfed infants have breastfeeding jaundice, whereas 2% have breastfed infants have breast milk jaundice. Milk is less, fed is more. After 7th day, good to see Yash Gehlot. Very good. Yash, you are from which part of the country and what is your dream branch? So every day I want to know at least 1 to 2 students, what is your dream branch? So Harek success story begins with a dream, doctor. Remember, if you don't know or if you don't dream, first एक dream है ना, एक target होता है, उसको achieve करने का एक journey होता है. So that's the reason you should imagine, hey, I'm going to be a plastic surgeon, I'm going to be a cardiothoracic surgeon, I'm going to be a nephrologist, neurologist, neurosurgeon, etc., etc. Very good. Good to know, Yash, you are from Rajasthan. Badhiya. So, Breast milk jaundice occurs after 7th day, but breastfed within 1 week. Max breast milk jaundice can reach 10 to 30. But breastfeeding may reach more than 12 milligram per deciliter. Breast milk jaundice peaks at 2 to 3 weeks. If breastfeeding is stopped, then the serum bilirubin values will fall down. Breast milk jaundice responds to phototherapy, whereas breastfeeding responds to more frequent breastfeeding. Typically, glucuronidase in the milk lead to breast milk jaundice, whereas a decreased milk intake, dehydration, reduced caloric intake, they are the ones which are responsible for the breastfed jaundice. Doctor, definitely tomorrow's examiner is going to ask one question on breast milk versus breastfeeding jaundice is what I want to underscore to all of you. Now, doc, the types of bilirubin, if you take, unconjugated is indirect, it binds to albumin. It is fat soluble, it can cross the blood-brain barrier, and it is very toxic to nerves. Whereas conjugated binds with glucuronic acid, water soluble, excreted in the urine and stool. The differences you should know. Once more, physiological jaundice, pathological jaundice, you should know the differences. Physiological jaundice after 24 hours. It rises by less than 5 milligram per deciliter. Maximum intensity by 4th or 5th day if it is a term baby, and 7th day in preterm. And serum level is less than 15 milligram per deciliter in physiological jaundice. And it is not detectable clinically after 14 days. So these are some of the things about physiological jaundice. Whereas pathological hota hai, it appears within 24 hours. Within 24 hours, please don't forget. And the rise can be more than 5 milligram per deciliter. Serum bilirubin can go beyond 15 milligram per deciliter. And jaundice persisting, physiological jaundice persisting after 14 days is also considered to be pathological. And quite often, stool which is clay colored, white colored, urine staining yellow, clothes will get stained yellow. And direct bilirubin more than 2 milligram per deciliter, more than 2 milligram per deciliter is the feature of pathological jaundice. That is what you need to remember. So, differences between physiological, pathological jaundice. Short aane wala question. One more thing, breast milk jaundice, breastfeeding jaundice. You should know the differences between the two. Barabar? So, a child has a vocabulary of 4 to 6 words. But the main mode of communication, social interaction is all non-verbal. What is the possible age? 15 months. So, doctor, please don't forget, gross motor, fine motor, language, and social cognitive. So at 15 months, he can walk backwards. He uses a cup. He uses 4 to 6 words and temper tantrums. They're all 15 months. 9 to 10 months, he crawls, pulls to stand, says Mama Dada, which is non-specific, uses the 3-finger pincer grasp. He waves bye-bye, pat the cake. So these are the things about the developmental milestones. Definitely puchne wala question hai. Similarly, 18 months, 2 years, 3 years, 4 years, 5 years, you should be very sure. Hopping by 4 years, tricycling by 3 years, climbing stairs with alternative feet by 3 years, copies a circle 3 years, copies a square 4 years. Build a tower of 6 cubes by 2 years. Build a tower of 2 to 4 cubes by 18 months. All these things. Kadak hona hai doctor, kal ke exam ke liye. The most common bacterial cause of the diarrhea in the children, enterotoxigenic E. coli. Confirmed. Diarrhea is a favorite topic in pediatrics. Microbiology, आपके मुट्ठी में रहना. If you want to become a topper in entrance, how much you can score in microbiology, biochemistry, a sub, oh my God, evaporable subjects. But if you conquer them, your score becomes higher. So now, doctor, a child is brought to the pediatric OPD with fever, 24 hours duration. There is a chest infection, 3 episodes, foul smelling, bulky stools, steatoria, respiratory infections will make you to think of cystic fibrosis. A child has a rash with recurrent infections, decreased platelet count, reduced IgM. You need any other clue? Wish-Kotarbic syndrome. Once more, all primary immunodeficiencies, Job syndrome, Wish-Kotarbic, etc., you need to have in your tips. Combined variable immunodeficiency, chronic granulomatous disease, which is cell-mediated, which is humoral immunity, everything we discussed in microbiology, you need to be 100% sure. A 7-year-old child presents with ambiguous genitalia. So, doctor, congenital adrenal hyperplasia, chodega nahi examiner. So, height, weight, BP, sab kuch normal limits. Labia appears bifid with 2 separate perineal openings. Phallic length was 2.5 centimeters. No palpable gonads in the inguinal region. That means it is not testicular feminization syndrome. Mullerian structures are intact. That means it is not Mullerian in the agenesis. So it is a congenital adrenal hyperplasia, which is simple virilizing form of congenital adrenal hyperplasia. Whereas 21 alpha hydroxylase deficiency may the classical salt wasting type of congenital adrenal hyperplasia is what you see. A child has decreased level of LH, FSH, testosterone, delayed puberty. What is your diagnosis? Kalaman syndrome. Kalaman syndrome. So it is a hypothalamic hypopituitarism. So hypothalamus is not instructing the pituitary to produce the pituitary hormones. Kalaman. Prader-Willi syndrome. What is elevated? Ghrelin levels are elevated. So doctor, a little bit about ghrelin. Ghrelin hota hai circulating hunger hormone. It is also called circulating orexogen, appetite regulating hormone, growth hormone, secretagogue, motilin related peptide. ये सारे नाम ghrelin का ही होता है. What increases the ghrelin? What decreases the ghrelin? Leptin, fasting, GnRS, thyroxine, sleep deprivation, lean people, low BMI, anorexia, increased ghrelin. Food intake, glucose, lipid, insulin, somatostatin, obese people, high BMI, PYY, they decrease the ghrelin. That's what you need to remember. One of the favorite questions. So Prader-Willi syndrome is a complex genetic disorder. You have hyperphagia, mental retardation, short stature, muscular hypotonia, severe obesity, learning difficulties. So in all these people, the circulating ghrelin levels are high is what you need to remember. So what is the most common tumor of the fetus and newborn? Tumor, sacrococcygeal teratoma. It is the most common tumor found in the newborns, occurring 1 in every 35,000 live births is what you should remember. Now once more, doctor. Wilms tumor, neuroblastoma. Wilms tumor, neuroblastoma. 10 points about each of them. You need to have in your fingertips. Barabar? You'll remember my word, right? आप एक 100 पेजेस नोटबुक लगाओ, रोज मैं आपको बताता हूं 3-4 सीक्रेट टॉपिक्स, शूट शॉर्ट आने वाला टॉपिक्स. पेपर आउट. Only thing is you need to go back to the onlinembbs.com video library and should be able to do the revision. Okay, so stage 1 Wilms tumor, how do you want to treat? So laparoscopic nephrectomy, earlier days open radical nephrectomy was the first choice, but now it has become popular to use laparoscopic nephrectomy. So stage 1, these tumors are only in the kidney, and the surgery can completely remove the tumor along with the entire kidney, and children who are younger than 2 years with small tumors may not need any other treatment other than the surgery. So doctor, once more. Treatment recommendations of Wilms tumor. You have to be very sure. Stage 1 में क्या करेगा? Stage 1 focal anaplasia में क्या करेगा? Stage 2, Stage 3, etc., etc. I leave the literature for you. A large for gestational age baby delivered at 40 weeks is found to be lethargic. The blood sugar measured 35. How do you want to manage? So typically, large for gestational babies commonly born to the diabetic mothers are at a risk of developing severe hypoglycemia and jitteriness and seizures, etc. So 10% IV dextrose. A 6-year-old child is admitted for seizures. He had been on tacrolimus, prednisolone. His sodium 136, serum calcium 7.5. What is the cause? It is tacrolimus toxicity. So what is tacrolimus? Tacrolimus, what are the features of toxicity? Remember tacrolimus. Tremor, alopecia, hypertension, renal insufficiency, skin cancer, hyperlipidemia, IDDM, magnesium wasting, uric acid elevation, seizures. Anything can happen. So increase uric acid, increase potassium, increase serum creatinine, and decrease magnesium characterizes the toxicity caused by the tacrolimus is what you need to remember. So you use 2 types of parenteral nutrition, 10%, 20%. अच्छा, इन दोनों के बीच में क्या फर्क है? 10% में 10% and 20%. So you should know that there is a higher phospholipid to triglyceride ratio, less energy per caloric content, and higher serum phospholipid concentrations. So basically, the triglycerol concentrations 10%, 20%, 30% weight to volume ratio it is. So I leave the literature for you. What is intralipid? What does it contain? Okay, it's a passing comment. Now comes the most important topic for the examiner doctor. I'm going to spend a little longer time. So every day's discussion, we will take 2-3 longer review of 2-3 topics, right? So that's a plan. Bartter syndrome. What do you see? So first of all, there are 3 syndromes you have to be 100% sure, doctor, when you are going for the NEET PG exam. Definitely they will ask. Gitelman, Bartter, Little. Bartter is like loop diuretic. So loop diuretic, where does it act? Ascending limb of loop of Henle, sodium potassium 2-chloride channel. Sodium potassium 2-chloride channel in the ascending limb of loop of Henle. Just like the loop diuretics act, the same thing is Bartter. So Bartter syndrome guy is like guy who is like lifelong taking loop diuretics. Then Gitelman is like thiazide diuretic. Thiazide diuretic act on the sodium chloride co-transporter in the distal convoluted tubule. Then Liddle syndrome is like a person, normally aldosterone will come and open up the sodium channel and causes the sodium retention. But here, even without aldosterone only, the sodium channel is constitutively hyperactive and it is open. So that is the whole problem. So Liddle syndrome is, as such, you are taking as such, you are in a state of hyperaldosteronism. Though aldosterone is normal, it is like taking amiloride, which also opens constitutively the sodium channels in the collecting that, right? So now with that background, और एक बार बोलो, Bartter is like taking loop diuretic and the problem is in the ascending limb of loop of Henle where sodium potassium 2-chloride channels are blocked, just like you are taking loop diuretic. Point number 2. Gitelman is like taking a thiazide diuretic where sodium chloride co-transporter of the distal convoluted tubule is blocked. And Liddle syndrome is constitutively hyperactive and opened up sodium channels in collecting that. Similar to you are taking the amiloride is what you need to remember. Now, Bartter में क्या होता है? Bartter होता है loop diuretic. So loop diuretic if you are taking, you will develop hypokalemia, metabolic alkalosis, hypercalciuria. Loop diuretic loses calcium. That's the reason hypercalciuria, salt wasting. It is autosomal recessive disorder. Defect in the sodium reabsorption in the thick ascending limb of loop of Henle. So normally loop of Henle is important to maintain the medullary osmotic gradient. So all this medulla, you need to maintain osmotic gradient, which will enable the movement of the water, reabsorption of the water. So if you look at the loop of Henle, the descending limb is highly permeable to water. This descending limb is highly permeable to water because it has aquaporin channels. Ascending limb has a thick and a thin part. The thin ascending limb of loop of Henle, thin part typically sodium passive transport होता है. Thick part of ascending limb of loop of Henle, there is a sodium potassium 2-chloride channel which lead to active sodium absorption. That's what you should remember. Similarly, whenever the chloride is unable to enter into macula densa, whenever the person is having Bartter syndrome, sodium potassium 2-chloride channel is blocked. Because of that, the amount of chloride entering the macula densa, once it decreases, then the macula densa, there is an increase in COX-2 production, and that leads to increased prostaglandin E2, and that directly stimulates the renin, and that leads to hyperaldosteronism. So these are all the issues. So increased prostaglandins in the macula densa is another reason for the pathophysiology in case of the Bartter syndrome is what you need to remember. Now, how many types of Bartter that you know? Type 1, 2 and 4 are perinatal and often they are associated with maternal polyhydramnios, neonatal salt wasting and several episodes of recurrent dehydration. Then classic Bartter syndrome is called type 3. It manifests in childhood with failure to thrive with recurrent episodes of dehydration. So the biochemical feature of Bartter, please don't forget, hypokalemic metabolic alkalosis with hypercalciuria characterize the Bartter. And the problem is a defective sodium chloride potassium transporter in the ascending loop of Henle is what you should remember. So typically a history of maternal polyhydramnios without prematurity and dysmorphic features like triangular faces, protruding eyes, large eyes with strabismus with a drooping mouth, they can be the presenting features. But in these people, what's happening? They are losing, typically in these people, there's a defect in sodium reabsorption in the thick ascending limb of loop of Henle. So that is the reason, typically these people, BP is normal. BP, normal, Bartter. That is the difference between Liddle and Bartter. Liddle में hypertension होता है, Liddle में hypertension होता है, मगर Bartter में normotension होता है. But Bartter में hypokalemic metabolic alkalosis होता है and serum renin levels are often marked. So it is like the chain of events you should understand by now. So typically in the ascending limb of loop of Henle, sodium, potassium, 2-chloride channel is defective, doctor. Because of this defect, the amount of chloride touching the macula densa decreased. Because of that, macula densa is producing excessive prostaglandin. Because of that, there is an increased renin. And because of the increased renin, there is hyperaldosteronism. And because of the hyperaldosteronism, there is hypokalemic metabolic alkalosis in these people. But generally, hyperaldosteronism guys will show blood pressure high. But in this, the blood pressure is normal. Normal. Because it is like taking loop diuretic. Bartter is like loop diuretic. So they are losing water, everything. So that is the reason BP is normal in these people who have Bartter syndrome. Otherwise, the dyslipidemias that you see, they all look like dyslipidemias of the hyperaldosteronism patient. And since loop diuretics lose calcium and a lot of calcium is lost into urine, that can lead to nephrocalcinosis in case of the Bartter syndrome is what you need to remember. So how do you diagnose? Severe hypokalemia, less than 2.5, with metabolic alkalosis, hypercalciuria, hypomagnesemia. So they are the features. Now comes the Gitelman. Gitelman का दूसरा नाम होता है Bartter syndrome variant. Phenotypically, physically, it looks very similar. It also causes hypokalemic metabolic alkalosis. But the difference is, Bartter में होता है hypercalciuria. Hypercalciuria. Whereas Gitelman में hypocalciuria. So that is the difference between the two. Between the Bartter and Gitelman. Gitelman also shows hypomagnesemia. And Gitelman presents more in the late childhood or early adulthood. And the primary defect is in the thiazide sensitive sodium chloride co-transporter. And it is more benign. Gitelman is good. G for good. So in late childhood or adulthood, it presents. In distal convoluted tubule, only 7% of sodium chloride reabsorption occurs. unlike ascending limb of loop of Henle. That's the reason the amount of volume loss that you see in Bartter versus Gitelman, if you take Gitelman, it is a less significant volume loss. And decreased intracellular sodium will activate the sodium calcium exchanger, leading to hypocalciuria, hypermagnesiuria, but hypermagnesiuria. That's the reason there is a hypomagnesemia. So once more, remember, Bartter versus Gitelman. A lot of times examiner will ask, Bartter will have hypercalciuria, but Gitelman will have hypocalciuria. That is the difference between the two, is what you need to remember. So what is the differential diagnosis for this Bartter, Gitelman? If there is any Cons syndrome, but Cons syndrome में primary hyperaldosteronism में low renin high BP रहता, but Bartter में high renin because of high prostaglandin, but a normal BP, that characterizes the Bartter. Then vomiting and bulimia, they will show a low urine chloride. Then, so that is they are the fundamental differences. So, urinary calcium is most important. Urinary calcium is most important thing to differentiate Bartter and Gitelman. Urinary calcium high, then what do you say? Bartter. Urinary calcium low, then you say Gitelman. Similarly, urinary calcium to creatinine ratio. If it is more than 0.2, it is Bartter, less than 0.2, it is Gitelman. So that is the point you need to understand. Another thing, if you treat hypokalemia, it will correct the hypercalciuria in the case of the Bartter. So these are some of the important points that you need to understand. So how do you treat Bartter? Bartter may prostaglandins increasingly produced in macular densa. So you need to block that PGE2 production by giving indomethacin. You have to block the aldosterone by giving spironolactone, because increased PGE2 is causing increased renin, is causing increased aldosterone. So you have to antagonize that with spironolactone. You have to replace potassium and magnesium. So you have to give a combination of NSAID to antagonize PGE2 and a potassium sparing diuretic. So that is the treatment. Shanti, Shanti, Shanti. So once more, doctor, you should sit with your classmates और Bartter little Gitelman को अच्छा मसाज करके बिठाओ, ताकि कल के एंट्रेंस में डेफिनेटली आने वाला टॉपिक है. So what is the prostaglandin analog used in PDA? We use alprostadil, misoprost, which are all PG-even. So doctor, you should know, misoprostol, gemiprostol, alprostadil, they're all what? Prostaglandin analogs. PG-even analogs. PGI2, ipoprostenol. PGF2 alpha, letanoprost, carboprost. And prostaglandin E2 is dinoproston, which is used intravaginally. So that's the point you need to understand. So alprostadil is used to maintain the PDA because ductus arteriosus is very sensitive to prostaglandin E1, is what you should remember. A baby born to the patient suspected to have chlamydial infection, you should always get a conjunctival smear. There's a testicular lump, increased AFP, that is a marker of York sac tumor. Male pseudohermaphroditism, genotype is XY, but phenotype will show female external genitalia. Then you call male or female pseudohermaphroditism depends on genotype. You will call male pseudohermaphroditism if it is XY genotype with female external genitalia. You call female pseudohermaphroditism if it is XX genotype with male external genitalia, is what you should remember. 3-beta hydroxysteroid dehydrogenase deficiency. What does it lead to? Typically, it leads to increased levels of DHEA, dihydroxyepiandrosterone. So cholesterol become DHEA, DHEA become androstenediol, which is controlled by 3-beta HSD. Androstenediol converts into testosterone. By the action of 5-alpha reductase, it becomes dihydrotestosterone, and testosterone becomes estradiol by the action of the aromatase. So all these enzymes, you have to be very sure about it. So what do you see in protein energy malnutrition? Glossitis, nail changes, flaky paint dermatitis, they're all the features. In ASD, ostium secundum is most common. मेरे प्यारे भारतवासियों, और एक बार ASD का टॉपिक जो होता है बहुत इंपॉर्टेंट टॉपिक है कल के एग्जामिनर, नीट पीजी एग्जामिनर के लिए. So let us talk about it. So this is the septum primum. Between the two, you have ostium primum. This is septum secundum. Between the two, you have ostium secundum. Now, doctor, let us talk about ASDs. 10 points about ASDs. Are you ready with me to do the revision? 10 points about ASDs. कल के entrance के लिए. ASDs are 8 to 10% of congenital heart defects in children. Secondary ASDs are 2:1 female-male ratio, but sinus venosus ASDs is 1:1 ratio. 30 to 50% of congenital heart diseases are all ASDs. Majority are sporadic, but sometimes they can be genetic. Like Holt-Oram syndrome, where patients have hypoplastic or absent thumb, radius, phocomelia, first degree heart block, ASD, Holt-Oram. Similarly, families who have secondum ASD also have got heart block. So of all secondum ASD, 75%, coronary sinus ASD is least common, which is only 1%. Secondum ASD is typically at the site of fossa ovalis, the defect is found. Secondum ASDs are generally single or sometimes multiple. Multiple is fenestrated atrial septum. Secondum ASD can be associated with anomalous pulmonary venous return, VSD, valvular stenosis, persistent SVC, mitral valve prolapse, Holt-Oram syndrome, anything can be associated. Ostium primum is typically in the lower portion. If you look back, ostium primum. So, ostium primum is in the lower portion of the atrial septum and overlies the mitral and tricuspid valves. Then you should remember one important point. Ostium primum defects are associated with a cleft in the anterior mitral valve and septal tricuspid valve leaflets, and small ventricular septal defects can be associated. Then sinus venosus type of ASD, it is commonly associated with the point of entry of SVC into the REA. Then anomalous drainage of the right upper pulmonary vein most commonly is associated with SVC type of ASD. That's a point you need to remember. Similarly, IVC type of TAPVC, anomalous pulmonary venous circulation, typically is associated with a typical scimitar-like appearance on X-ray. It's called scimitar syndrome. So sinus venosus type of ASD associated with IVC type of anomalous pulmonary venous drainage is called scimitar syndrome, is what you should remember. Then most of the patients of ASD, they're all asymptomatic. If they are infants, they have pulmonary overcirculation, recurrent respiratory infection, failure to thrive. Older people will develop fatigue, dyspnea. Then left precordial bulge will be found with the ASD. And in ASD, what is happening? Left atrial blood is going to right atrium, and right atrium blood is going to right ventricle. So increased right ventricular flow. That's the reason a prominent right ventricular impulse along the lower left sternal border is what you see in case of ASD. Wide fixed splitting, systolic ejection murmur at the upper sternal border, a short rumbling mid-diastolic murmur along the lower left sternal border. They are the auscultatory findings. Normally, X-ray may look normal, but significant shunt hai to, there is a right atrial enlargement with right ventricular enlargement, increased pulmonary vascular markings, a prominent pulmonary segment. So they are the associated features. Now comes the most important MCQ entrance. Secondum ASD में right axis deviation होता है, right ventricular hypertrophy and a RSR pattern in the lead weaver. Whereas ostium primum defect में you have a left axis deviation. So primum lead to left, ostium secondum lead to right axis. So this is what you need to remember. So it is very easy to remember. LMNOP, QRS. So right lead to right in secondum, L, left in primum. So that's what you should remember. So two-dimensional echo, color Doppler, pulsed Doppler, transesophageal echo, they're all essential investigations, especially if you want to identify SVC type of ASD, then transesophageal echocardiography is required. Cardiac catheterization is indicated if you are suspecting any pulmonary vascular disease, so that you can calculate pulmonary vascular resistance. So whenever ASD patients left to right, more and more blood is going more and more to right ventricle, more and more is going into pulmonary artery, they can develop pulmonary arterial hypertension. That's the reason in any given case of the ASD, one of the challenges tomorrow as a cardiologist is, can I know how is the pulmonary vascular resistance? Is this patient is ASD with PAH or ASD without PAH? PAH है या नहीं समझने के लिए cardiac catheterization करना पड़ेगा. So when will you close ASD if it is large? How do you know it is a large shunt? There are some criteria. Chest X-ray wise, echo wise, ECG wise. Similarly, color Doppler, diastolic flow rumble in the tricuspid area. So they're all the indicators. So you can use several closure devices that can be delivered to cardiac catheters. So when do you do non-surgical? When do you do surgical? You need to understand clearly. So that is the story of ASD doctor. Wide fixed splitting and pulmonary hypertension leading to reversal of the shunt. Ostium secondum developing right axis deviation and primum developing left axis deviation is the favorite question of the examiner in ASD. So common causes of the congenital stridor in a child: laryngomalacia. Purposeful movement, when will the kid start? 6 months. Swiping of the oral cavity should not be done if there is a foreign body ingestion, because you may push the foreign body deep into the respiratory system. Risomol में सोडियम होता है 45 millimoles per liter. Congenital TB में liver is the most common organ which is involved. Down syndrome में it is the VSD which is the most common cardiovascular lesion, because endocardial cushion defects are common in the Downs. Epstein's anomaly में होता है right atrial enlargement, left atrial enlargement, left ventricular enlargement, not the right ventricular. क्यों? भैया ये ट्राइकस्पिड वाल्व जो है जरा नीचे आ गया, नीचे बैठ गया. So abnormal placement of the tricuspid valve more down, leading to atrialization of the ventricle. Ventricle atrium के जैसे बन गया, atrium ventricle के जैसे बन गया. So that lead to enlarged right atrium. And generally, tricuspid atresia patients with Epstein's anomaly, they will only survive if their ASD is patent. So through ASD, the right-sided blood will move into the left side, and that is the reason Epstein's anomaly also comes under cyanotic heart disease. But here, what is the specialty of those cyanotic spells? There will be intermittent cyanotic spells, they are called as. When you want to sit and examine patient, he may not show cyanosis. But when examiner comes and you have to present the case, then he may show cyanosis. So it is intermittent cyanosis. So that will move the blood from the right atrium into left atrium, and that lead to development of cyanosis. So left atrial enlargement, left ventricular enlargement, right atrial enlargement can be there, but not right ventricular enlargement. That is Epstein's anomaly. Kernicterus. It can lead to long-term neurodegenerative effects. Opisthotonus, deposition of the bilirubin in the basal ganglia. Typically, kernicter occurs the moment bilirubin is more than 25. Lecithin sphingomyelin ratio is used to assess the lung maturity. Apnea in an infant is more than 20 seconds. 2 to 5 year old child with diabetes, what is your target HbA1c? It should be maintained less than 9%. Refsum's disease. It can lead to ataxia, ichthyosis, retinitis pigmentosa, etc., etc. So retinitis pigmentosa leading to impaired eyesight. Similarly, deafness, anosmia, ataxia, ichthyosis, dry scaly skin, cardiac arrhythmia, shortened fingers, toes. They are all the features of Refsum's disease. In this, there is an impaired oxidation of the phytanic acid, leading to elevated phytanic acid levels in the CNS. Is the Refsum's disease. But ajeeb baat kya hai bole to, these patients have retinitis pigmentosa. Retinitis pigmentosa will present with the evening hote hi, there will be dark blindness. So generally, vitamin A deficiency may be आपको dark blindness हो सकता. But for the vitamin A deficiency associated night blindness, you have to do green leafy vegetables. But don't do that in Refsum, because in Refsum, phytanic acid, which is already abnormally high, if you give green leafy vegetables, it will further worsen. So that's the point you need to remember. So night blindness is a feature of both vitamin A deficiency and Refsum, but in Refsum, don't give too much of green leafy vegetables. Simple febrile seizures, typically 1 to 2% will go into epilepsy. First sign of pubertal development in boys will be testicular enlargement, whereas in the girls will be thelark. The breast bulging is usually the first sign of puberty. Sweaty feet smelling urine, typically is a feature of isovaleric acidemia. Coarctation of aorta patients also have a bicuspid aortic valve as an associated abnormality which you need to look for. Exclusive breastfeeding, you need to do up to 6 months of age. 5-year-old boy has fever and rash, and on the first day, and the rash disappears after a few days, and then the child develops ataxia. So all this is the classical feature of chicken pox. A child less than 1 year with asthma, you have to use MDI with spacer with mask. Tinea versicolor, if you do woodland, it looks yellow. Yesterday we discussed in a great detail nocturnal enuresis. So how do you treat in a 14-year-old child? You have to give positive reinforcement. So a lot of times it is a behavioral problems that is the underlying root cause of the nocturnal enuresis. And 3-beta-HSD, just before we have seen any deficiency lead to increased DHEA. Increased DHEA is what you should remember. So doctor, that brings us to the end of today's wonderful evening. Thank you all for participating, and don't forget once more, tomorrow 6 o'clock in the evening, we are continuing our journey of pediatrics. Saturday, Sunday, we should finish the remaining almost 200 questions are there. We will try to finish it and say ta-ta, goodbye to pediatrics, which we have started on the last Sunday. So from Monday onwards, we will start SPM, sleep promoting medicine, right? वो भी एक हफ्ते में एक 500-600 क्वेश्चंस लेके खत्म करेंगे. Like that, in the next 14 weeks, we are going to have in this crash course almost 150 hours of combined study and then get ready for the exam. Good night and read well. Thank you.